to give an overview today of xylazine and then turn things over to our other two physicians who are on our panel. And contact information is there. I work for Health Management Associates. I've been in San Diego County providing care for 27 years and really enjoy doing addiction medicine. It's an extremely rewarding career. So we're here this afternoon to hear a little more about fentanyl and a lot about xylazine and the emerging threat that xylazine is. This has gotten a lot of public attention over the past 9 months or so, with the DEA report coming out last year in October 2022 regarding the amount of xylazine available across the entire US now. So I've provided the amount of increase that we've seen in the West. It's 112% increase. The Northeast, where xylazine has been present for some time, is not seeing as big of increases as they are in other places. Additionally, not just are we finding it in the samples that are being tested in the forensic lab, we're finding it both mixed with opioids and stimulants, but we are also, xylazine is present in a lot of the deaths that we are experiencing across the country related to our overdose epidemic. So specifically in the West, there's been a rather large increase, 750% increase in deaths compared to only 100% increase in the Northeast, where, xylazine has been present for a long time. Additionally, there was a large press release earlier in the year and information available from the Office of National Drug Control Policy regarding this emerging threat. All three of us will be speaking on the medical panel about xylazine, so I'm just going to hit fairly high-level topics. What is xylazine? It is an alpha-2 adrenergic receptor agonist. For those of you who are prescribers or administer or dispense medications, it is like Clonidine, a medication that has been available for a long time. Xylazine is actually approved by the Food and Drug Administration, not for humans, but for veterinary uses. It was taken out of trials many, many decades ago for human use because it was too effective at lowering blood pressure and has, though, been approved as a veterinary anesthetic to sedate and produce muscle relaxation. Why would people add it to fentanyl or to other drugs? Well, it is longer acting than fentanyl. And so people say things like, it gives fentanyl legs. It makes my fentanyl last longer because fentanyl is quite short acting. And although it does cause some respiratory depression, it doesn't cause as much respiratory depression as fentanyl. And for that reason, the option would be to increase the amount of fentanyl present or fentanyl derivatives, which are even more potent. You could get more high that way, or you could use an agent that kind of augments the effects of fentanyl. And so that's what xylazine does. But it has some really idiosyncratic dangers. And we've already talked about that it decreases the respiratory drive. It lowers blood pressure. I mentioned that. That's actually why it was human trials were discontinued, because it was too effective at that. And it slows the heart rate. From other things that go on, it is sedating and can cause coma. It can cause some body temperature dysregulation. And so that is important when we think about people being exposed to elements, both cold and hot. It can cause significant heart and kidney problems, and we'll talk about that a little bit more in a few minutes, at least, the kidney problems. And it can cause skin necrosis. Now, Dr. Hardin is going to show us some not so pretty pictures of skin necrosis that is occurring related to this medication, and talk about how xylazine can cause skin necrosis, not just from injecting, but even from consuming xylazine orally. And the skin necrosis that is present is not always present at injection sites, but even distal to, very far from injection sites. So it does increase the risk of overdose, but in the mind of the drug manufacturers, it's slightly safer than just increasing the amount of fentanyl or providing fentanyl derivatives. So what can we do about xylazine? Well, we need to test for it. And I look forward to hearing from our other presenters and Dr. Lev about the testing that is going on within San Diego County. But one of the things that is new this year is that we did just come out with xylazine test strips. So xylazine, like fentanyl, is not detected in the majority of tox screens that are done. It can be detected with expensive equipment when we send patient samples away for testing when we use mass spectrometry and chromatography, but it's not done in point of care testing until earlier this year when we came out with an actual strip. So similar to fentanyl, it needs to have a separate test above and beyond the other tests that we are doing. We need to educate. Our messages have been fairly consistent for many years from a harm reduction perspective, but there are some unique messages that we need to educate about that I'll review, and we'll also have Dr. Makau review some of those messages as well. And we need to provide oxygen or rescue breath in addition to our normal overdose intervention. And then obviously we need to treat people for their underlying substance use disorder. So when we talk about harm reduction, we, like I mentioned, kind of need to change the messages that we're providing to people. So in the original the opening slide, there was a gentleman lying on the ground, a model who's posed lying on the ground. The reason that that is so important to understand is that this xylazine has such a rapid onset of action that there have been some really adverse consequences of people using while standing or sitting and actually falling across the railroad track and then having an adverse outcome or being taken advantage of. But we don't usually think about educating our patients that they shouldn't use drugs while standing up or that they shouldn't use drugs while sitting down. How would you use this? So because it is so rapid of an onset and so severe in the sedation, people will literally fall forward or fall over and can fall from a standing position all the way down to the ground and hurt their head or other things that way. Additionally, when people say fall forward, they can literally cause nerve damage and vascular problems because they may be lying in that position for up to 6 hours while they are severely sedated from this medication. So we have, or drug in this case, we have been changing our messages and talking about from a harm reduction perspective that we want people, if they're going to use, not to use on concrete or asphalt. They need to be lying on a soft surface that their friends, hopefully, or family will roll them over every couple of hours or move them so that they don't actually cause tissue breakdown from not getting blood flow to, say, their hand, if they're lying on their hand for 6 hours and have no blood flow going to that area. Or that they need padding underneath their, say, elbows or the heels of their feet. Because you're not moving and because you're not getting good blood flow, you're actually causing muscle decomposition. And therefore, that can cause kidney damage. And so we need to educate people and the people that they are going to be using around what they need to look for. So if somebody's urine is extremely dark colored, reddish, that is an indication of muscle and kidney damage. And then, of course, never use alone. One of the things that I have over here that you can click on these links when we share the PowerPoint presentation is actual educational flyers. So our state has an educational xylazine flyer available in English, but doesn't yet have one available in Chinese or Spanish or Polish or Arabic. The San Diego County Substance Use Overdose and Prevention Task Force is working on a xylazine handout, which will be in all 5 of our major languages within San Diego County, and that should be available soon. And I know that they'll send that out, their full distribution list. But in the interim, while we don't have one available within California in Spanish, you could use this one that was developed by the state of Illinois. So we are also having to educate people regarding the wound. So I mentioned skin necrosis. And it's important to understand that that's not because somebody doesn't have sterile technique when they're doing an injection. I mentioned that that can even occur for people who are using this orally. It's not a bacterial infection that's causing the wound. It's actual dead tissue. But it can get secondarily infected. Additionally, interestingly, and something many medical professionals may not have even thought about, is that we don't want to use hydrogen peroxide. If you have a really long living wound, you don't want to be killing all of the cells that are responsible for chewing up the dead tissue. And hydrogen peroxide will do that. And you also don't want to be drying out that tissue with alcohol. So you don't want to be using hydrogen peroxide or alcohol multiple times every day in order to clean the wound. You want to use sterile water. You want to use wound markers. This is not something that I had necessarily had to do in the past when educating patients, is talk to them about, draw with a Sharpie marker the size of your wound today. And if the wound is bigger tomorrow, then that is a sign that you need to go get some additional medical care. And then making sure that people use non-absorbent dressing. So most of our gauze and a lot of our Band-Aids and those kinds of things will actually stick to the skin. And so it's really important that we use non-absorbent dressings and let our patients know that this wound that looks really bad, which Dr. Hardin will show us pictures of, that yes, it looks bad, but if it doesn't smell, then it's not something you necessarily need to start taking antibiotics for. Again, remember, it's not always bacterial, it's necrotic, it's dead tissue. But if it's getting bigger or you are having large chunks of skin fall off, then those are things that we need to make sure that you get some medical care for. So what about treatment? Again, we need to change our messages. So xylazine is not an opioid. Because it's not an opioid, it won't respond to naloxone. However, it is most likely that opioids were included with the xylazine. It's possible that it was xylazine and stimulants, but more likely that it was xylazine and opioids. And therefore, you still need to give naloxone, even if it is a xylazine overdose, because you don't know what all was mixed in and what all the person took. I mentioned this is very long acting, and therefore it's super important that you give oxygen or rescue breath and call for transport to a hospital, because this can't be reversed. You need to make sure the person gets to a hospital, because if not, you're not going to be able to provide them with oxygen or rescue breathing for 6 hours. They are going to likely need intubation. Additionally, we have treatment concerns when we're talking about withdrawal or treating the underlying condition. So there is xylazine withdrawal occurring, and it's characterized by anxiety and dysphoria and restlessness above and beyond what we usually see with opioid withdrawal. And for that reason, we are having more difficulty maintaining people in treatment. People are leaving the emergency room, they're leaving the outpatient clinic, because they are so much more uncomfortable than they were from just opioid withdrawal historically. It doesn't respond to opioid agonists like methadone or buprenorphine, but we still do want to treat the underlying disorder if they're also using opioids or if they're also using stimulants. And I want to stress the fact, because some people have been very concerned about the use of buprenorphine or methadone in somebody who's got an opiate use disorder who also has been using xylazine, and worried that that makes it more likely that they're going to accidentally overdose on the methadone or buprenorphine. That is not the case. We must treat with medications for opiate use disorder, even in the context of xylazine. It is much safer to treat somebody with medication for opiate use disorder than to not treat somebody, even in the context of xylazine. So I have a couple of pages of resources here, but I am going to stop sharing and turn things over to Dr. Hardin now.
So my name is Jeremy Hardin. I'm one of the medical toxicology fellows out at UC San Diego. For those who don't know, this is a subspecialty of emergency medicine that focuses primarily on poisoning and drug overdose. So it's a good fit for this type of talk, which I'm excited to give to you guys. We're going to be talking about fentanyl and xylazine, both kind of in equal parts. I have their chemical structures here as well, and these slides will be distributed to you at the end. They have some notes in there, so if you want to review them, that's something you can also do. In order to talk about fentanyl, we first have to talk about opiates and opioids. And opiates, when you try to conceptualize what those are, these are things that come from the poppy plant. These are naturally occurring compounds. You see on the left there, the Papaver somniferum. There's the poppy plant itself. The peak global supply comes from Afghanistan. And these are drugs that we all know: morphine, codeine, and the lesser known thebaine that's not used medically as much as the other two. Now, when we talk about opioids, these are a much larger category. They include all opiates like morphine and codeine, but they also include, more relevant to the modern era, these new synthetic and semi-synthetic compounds. This is where we get into heroin or diacetylmorphine, fentanyl, hydromorphone, oxycodone, all of the different synthetic fentanyl derivatives. Those are all opioids. So just a little bit of terminology. You can never go wrong with calling something an opioid, because that's the broader category, but the opiates are the things that truly come from the plant itself. Now, when we talk about fentanyl, a synthetic compound, it's extremely potent, 50 to 100 times more potent than morphine. Some of the fentanyl analogs, these newer research chemicals or things like carfentanil, can be up to 10,000 times more potent than morphine. They're extremely short acting, and when used in a non-monitored setting, which we'll talk about, they can be extremely dangerous. This photo here, a lot of times when people take photos of fentanyl, they're always next to very small objects: pennies, pencils, needles. This photo shows what 2 milligrams or 2,000 micrograms of fentanyl looks like. Easily a lethal dose for someone who even regularly does fentanyl. And this is in the context of a normal medical dose that I may administer at one time in the emergency department, maybe between 50 to 100 micrograms. That is 2,000 micrograms. So you can imagine it would be very difficult to handle and use this amount of drug, particularly in a non-medical setting. There's lots of different formulations for fentanyl. Pretty much anything you can imagine can have fentanyl in it: intravenous, intramuscular, intranasal. There's fentanyl patches, there's fentanyl lozenges. And so it does not just have to be something that you inject or smoke. When it comes to fentanyl coming on the radar in the United States, it starts with these initial epidemic overdoses. One of them was actually really close to us in Orange County in the late 70s. That was the China White epidemic, if you've heard of that one. That was alpha methylfentanyl. And then later in the early 90s in New York City, we had the Tango and Cash 3-methylfentanyl. These are basically rashes of drug overdoses in people who believed they were using heroin or other drugs that was adulterated with fentanyl. At this point now, in the mid 2000s, something like this, like a China White or a Tango and Cash, wouldn't even track on the radar, because we're just so completely in the fentanyl era. This is something that's, pretty much every major city in the United States is having this happen right now. When you look at some data here from the CDC, looking from 1999 to 2021, this is a good description of drug overdose deaths with involved drugs over the last 20 years. And you can see a dramatic rise in this gray line here. This is the synthetic opioids, primarily fentanyl, just really exploding in the mid 2010s. And it's important to note that a lot of this fentanyl is manufactured overseas, particularly in China or South Asia, then imported in bulk to Mexico, where it's then smuggled across the border. And San Diego, where we are now, is a major site of entry, which I'm sure the public health specialists will talk about. And it's important to note this can also be directly imported to you in the mail. People buy this off the dark web. The amount that you need for use is very low, as you saw, so it's not something that is difficult to smuggle. I'm going to get a little bit into the weeds here for just a second on the mechanism of action of fentanyl and opioids generally. They act on things called opioid receptors. These receptors are located all over your body and in your brain, and they produce different clinical effects that I'll talk about in just a second. It's important to know that there's different types of opioid receptors, and the different type of receptor is responsible for the different type of effect. And these receptors have also greatly been used for therapeutic benefit. For example, things like Narcan or naloxone that block this receptor, the opioid antidote that we talk about a lot. The receptor, if you have to know one of them, that's most important to know, would be the thing called the mu receptor. This is responsible for all the highlights of opiates. It's sedating, it's the euphoric effect associated with use, and as well as the dangerous respiratory depression and dependence associated with more chronic use. You also have the kappa receptor, which causes a characteristic physical exam finding, meiosis, which we'll talk about. And then there are some other more medical receptors for things like spinal anesthesia or analgesia, which is more relevant in the operating room setting where we use fentanyl. The clinical effects of fentanyl, once you know what to look for, these are things that are fairly obvious and can be noticed pretty rapidly on exam. There's both a intoxicating set of findings and as well as a withdrawal set of findings in the setting of abstinence from use. When it comes to intoxication, the findings obviously pain control, being sedated, sometimes to the point of coma, euphoria, meiosis, which is this classic finding of pinpoint pupils. I highly recommend, if you are ever concerned about someone who may have ingested an opioid, looking at their eyes as well as seeing how they're breathing is always a very important initial step to evaluation. When it comes to their breathing, fentanyl is interesting in that it causes both a low respiratory rate as well as a shallow breathing, and in high doses can actually cause the complete cessation of breathing. This is really how most people die from opiate overdose. They die from apnea and a respiratory death. It's important to note that the way that your brain and your brainstem prompts you to breathe is by two methods. One is by sensing the amount of carbon dioxide. The other is about sensing the amount of oxygen. For example, you see deep sea divers. Before they dive, if you watch them, they breathe as fast and as deep and as hard as they can for a couple of minutes to try and release as much of that carbon dioxide as possible, because the higher your carbon dioxide level is, the more it's actually a painful sensation. You can feel it if you hold your breath. That's prompting you to breathe. Fentanyl blocks this effect, and it also blocks the backup mechanism, which is the sensation of hypoxia or low oxygen, right, which happens much later than high carbon dioxide. And you can imagine that blocking both of those effects, particularly if you're extremely sedating, is profoundly dangerous, and that's what leads to death. It's also a cough suppressant, and it's important to know that heroin, diacetylmorphine, was actually first sold over the counter by Bayer in the late 1800s as a cough suppressant. That was kind of its first main medical indication. The withdrawal symptom, if you know the intoxication, you can anticipate the withdrawal. It's the other side of the coin. Instead of anesthesia, they have increased response to pain. Instead of euphoria, anxiety. Instead of meiosis or pinpoint pupils, they have mydriasis or dilated pupils. And they also have these classic findings of piloerection, or the hairs standing up, and yawning. It's a very classic finding to see someone who's both profoundly anxious and yawning. That's an unusual thing to see, and it should prompt you to think about fentanyl withdrawal. Something also worth talking about is what's the difference between an adulterant and a contaminant when we're talking about fentanyl being within the drug supply? And is it a contamination of the drug or an adulterant? We see a lot of people on the toxicology surface who believe that they're doing a different drug, something like methamphetamine or cocaine, and they actually end up doing fentanyl and basically going into a coma. And adulterants are intentional additions to drugs. Similar to how xylazine, like we'll talk about, is an adulterant for fentanyl and vice versa. They're often chosen for various properties, things like bitter taste. A lot of drugs like heroin are bitter, so you can fool people into thinking that they're getting high quality heroin by adding bitter bulking agents. The color, the consistency, that's how you see things like powdered milk or quinine, sugared chalk, starch being added into bulk drugs. Then you get into more augmented effects. You end up with things like speedball, which is a mixture of cocaine and an opioid, or amphetamines, or, which we're going to talk about more, is xylazine. There's also adulterants with malicious intent to poison and harm people, things like strychnine or gopher killer, thallium, and lead. Contaminants are different than adulterants. These are unintentional additions, usually due to the way that the drug is initially manufactured or stored. These are usually synthetic intermediates with long chemical names like NPP or ANPP. And it's important to note that while these may have clinical effects, they're generally not things that are intentionally put in by the drug manufacturer. So let's transition here to xylazine. I would encourage anyone who's really interested in this, if they want to do a bit of a deeper dive, there's an excellent series of short articles by Jan Hoffman in the New York Times. This is a couple of them chronicling xylazine over the last year. These articles are all absolutely excellent and are worth reading if you're really interested in this topic. Xylazine is an animal tranquilizer. It's used by veterinarians. You might hear it called trank on the street. And it first started off really being heavily used in Puerto Rico, where it was a not well-controlled horse anesthetic that proliferated onto the black market. Its mechanism of action, like we kind of heard about before, is that it's a alpha-2 receptor agonist. This is a picture of that alpha-2 receptor, and this is a receptor that's responsible for sedation and negative feedback. They decrease your amount of catecholamines, which is stuff like norepinephrine, and lead to these clinical effects of sedation, vasoconstriction, low heart rate, slow breathing, things like that. And drugs that we might know that work like this would be things like, for example, clonidine, which we talked about before, and then something like dexmedetomidine or Precedex on the inpatient setting. It's important to note this is very rapidly cleared from the body in less than a couple hours, and it's not something, unfortunately, that we see on routine drug testing. Its clinical effects, to not go too much into the repetition from before, but its sedation, its hypothermia, and skin ulceration, which we'll talk about, are the main findings, but it can also be a mimic of opioids even on its own, causing meiosis, low respiratory rate, and it does have, like was talked about earlier, a withdrawal symptom. I think it's important to note why people do this. It's not always the case that this drug is added solely at the discretion of dealers to, either harm people or to increase the duration of their fentanyl supply. It is also added a lot of times by demand, particularly for people like we were talking about who are looking for legs on their drugs. And I think there's an excellent quote here saying, it's sought after because the fentanyl is such a short-lived high. It's good, but it's so short that you end up nodding off or getting sick. And when they talk about sick, they're talking about withdrawing faster. So people will seek out fentanyl with xylazine because of the extended high, and it feels subjectively more like heroin with a prolonged duration of action. Now, the issue that this woman also brings up is that you can end up with a lot of xylazine, too much xylazine in your mixture, and instead of having this heroin-like effect. You end up getting profoundly sedated and you can fall asleep. She says you're sitting there 1 second talking and the next you're waking up hours later in a weird position. That's something that we're seeing a lot. Now, at this point, you can already see on her forearms have this extensive scarring. I'm going to apologize to everyone who's just coming off lunch, but I'm going to have some pretty graphic photos that are going to be on the next slide, but they're worth seeing because this skin necrosis seems to be such a classic finding now with xylazine. So without any further ado here, this is what xylazine skin necrosis looks like. It's pretty bad as far as drug-induced skin necrosis goes. Now, to be clear, not all xylazine skin necrosis is this severe. It all starts at some point, with smaller ulcerations, but the progression of this skin necrosis to these profound, severe, large necrotic lesions is something that we're seeing more commonly with xylazine. Like we talked about in the mechanism, xylazine is a vasoconstrictor, meaning it shrinks your blood vessels and decreases skin perfusion. And that type of vasoconstrictor that it is, the alpha-2, is also more sensitive to the cold. And so what we're seeing now is we may have a synergistic effect, both of the vasoconstriction, and also a lot of times we're seeing these effects in people who are often outside for prolonged periods of time, or they take it and they're lying on the cold pavement, or on the East Coast they're in the snow, and that dramatically increases your risk of necrosis. When it comes to these reports of distant necroses and people who, for example, inject xylazine or who are having necrosis in distant places, that part of it, I think, is currently in the toxicology literature less settled. From my own review and the review of our department, we're seeing a lot more of these necrotic lesions in sites that I would commonly associate it with injection drug use. Sites like the forearms, upper extremities, neck, like we see here, lower extremities, feet, and ankles. I have yet to see a case of someone who's having these distal ulcerations, for example, in their back, which you cannot easily reach with injectable use. So the jury is still out for us about whether or not these are local reactions to non-disclosed drug use, or if it's more of a synergistic effect of cold and systemic xylazine use that causes these effects. For example, you're on the pavement on a cold spot and the area that you did not inject is what's touching the ground and it becomes an early necrotic lesion. That is also possible. I think the jury is still out. Regardless, this necrosis is extremely severe and can often lead to secondary infection and amputation, which is extremely severe. When it comes to mortality, which is an important marker, I have two graphs here out of Philadelphia, which is one of the places with the highest xylazine prevalence in the country. On the left, you see the gray bar with a number of polydrug deaths that have positive fentanyl and xylazine detections. The dotted line is the percentage, so it's almost 25%, with again a drastic increase since 2014, a total number of 80. In 2019, up from less than 10 and undetectable before 2014. And on the right, you have your deaths. And you can also see in the dotted line, your percentage involved with xylazine is also increasing since the same time, up to about 30% most recently. So while we don't necessarily have the smoking gun on exact causality and mortality, these findings are extremely suspicious that xylazine adulteration in the supply is leading to increased mortality amongst drug users. When do you want to suspect this? You want to suspect it in any patient with opioid overdose who doesn't respond to naloxone. That should make you think of a polydrug injection. Important to note, xylazine is not the only thing out there. Benzodiazepines also worth consideration, along with a great many other sedating drugs. Anyone who's sedated, hypotensive, or bradycardic, you should think about xylazine. And certainly if they have skin ulcerations, you should be extremely suspicious about xylazine. And when I say don't respond to naloxone, I'm talking about generally doses greater than 10 milligrams of naloxone. And so for my last slide here, just talking about treatment, always give naloxone first. While it won't be expected to reverse the xylazine, we're all going to repeat this fact. You should give naloxone, especially given the propensity on mixing of opioids with xylazine. Always need to assess the airway, breathing, check a fingerstick glucose if you have medical response available to do so. Hypoglycemia can mimic these. In the emergency department, we worry about things like endotracheal intubation or atropine to fix respiratory and hemodynamic effects, along with epinephrine. The severe wounds will require, sometimes if they're infected, antibiotics, and most of them will require surgical debridement and potentially amputation. And it's important to note there's a lot of literature out there about Yohimbe, which is a alpha-2 receptor antagonist, different from clonidine and xylazine, which are agonists at that receptor. This is not approved for human use. You should not use this. This is in a veterinary literature, and we would caution against using that as an antidote. And when it comes to withdrawal, there's a point of contention about whether or not to treat withdrawal in a lot of these patients. We would recommend for it. And luckily enough, one of the prime medications that's used for opioid withdrawal classically is something like clonidine, which theoretically works very similar to the xylazine and should be a adequate medication for withdrawal symptoms. And harm reduction, which Dr. Makau is going to talk about a little bit, the most important is to never use alone. Having a, basically rapid onset comatose state while you're alone, regardless of where you are, is always extremely dangerous. And all patients should be cautioned against that. So thank you so much for your time.
Welcome, everybody. And I'm delighted to spend a few minutes with you talking about fentanyl and xylazine. My job, however, is easier because Dr. Shannon has already talked to us about the specific harm reduction for xylazine. And I'm just essentially going to sort of take a bird's eye view. And what I'm going to say will actually apply to all substance use. I am from California Bridge, and California Bridge is a program of the Public Health Institute, which acts under the auspices of the Department of Healthcare Services for the state of California. And our goal at California Bridge is to have access to high quality treatment for patients with substance use disorders in all California hospitals by 2025. And I'm delighted to share with you the fact that actually we are ahead of schedule. There are about 300 emergency departments in our state of California, and we already have the California Bridge program in about 278 of those at the present time. So that's pretty darn good. And what is our model? We are advocating that every emergency department have low barrier treatment. And what do I mean by that? That is, start buprenorphine in the emergency department for those patients who are in withdrawal and want to try the medication. And we also advocate the use of a substance use navigator to help those patients connect to continued care in the community. And of course, we are going to talk about the culture of harm reduction, what that is and what you can do to help. Now, there's always this question, the usual feeling is, substance use disorder, it's a moral failure. Those people just can't get their act together. However, now we are more sophisticated and we know that maybe it's not those people's fault. Maybe it's the genetics. But maybe it's not the genetics. Maybe it's an environment. So actually the answer is both. And addiction or substance use disorder is a combination of both genetics and the environment. And we will talk a little bit more about that. And that will help us understand what kind of tools we should bring to bear for harm reduction. Now, Dr. Jeremy sort of introduced us to opioids and how we started using them. Paradoxically, we actually found out in the 70s that we weren't being very clever. There was actually an endogenous opioid system already at play throughout evolution. And it turns out that, our bodies have an endogenous opioid system. And we have these small peptides, beta endorphins and enkephalins and dynorphins, that act on those receptors that Dr. Hardin talked to us about. And these receptors, when these peptides hook onto those receptors, they produce dopamine, a substance, a neurotransmitter that we are all aware of. And this dopamine gets used by the body to do all kinds of things. And we are still here today as human beings. We have reproduced thanks to the pleasure centers that taught us that, hey, sex is good and we need to produce more of our kind. And that was because of those receptors. Unfortunately for us, when opioids act on the same receptors, they don't just produce dopamine. They just flood the whole system with dopamine. And that's where all that big pleasure from doing drugs come from. We are just producing 2 to 10 times as much dopamine as we would normally produce with the endogenous system. So when a patient or when people take opioids or substances, they act on the ventral tegmental area, and then that influences also the nucleus accumbens and produces lots of dopamine. And when you have lots of dopamine, some people think that they are Superman. They can do all these incredible things that they wouldn't normally be able to do. Some people have trouble with impulse control. They become very aggressive. And where I am going is to sort of give you why patients we see who have done substances act the way they do. They are not being bad people. They are just being influenced by the amount of dopamine that's in their system. And unfortunately also, just because you take these substances and you get this high, you will never get that high again because the body is very clever. It downshifts the regulation of the receptors. And also your dopamine is no longer as efficient as it sometimes is. So that when there is withdrawal, you have downshifted your receptors. So you are looking for dopamine all over the place and you can't find it. And these people are in a terrible state. And so in an acute phase, although you get that high, most of the people we are dealing with are in this area. And what they are trying to do, they are just trying to be as normal as they can be. They are taking or continue to take drugs, not to get a high, but just to be normal. And also, I'll be talking about buprenorphine, which we use in the emergency department for treatment. And some physicians and some people are afraid that, it will be diverted. Yes, there is buprenorphine on the street, but people taking it are not taking it to get a high. They are taking it to get to as normal a level as possible. And some of the risks that we have with long-term use of substances, and that includes opioids and fentanyl that we are talking about, is overdose. And most of the speakers that have gone before me, we are trying to cut down on the number of people dying from overdose. There is increased crime rate in order to get money to pay for the drugs. Because of the dopamine fluxes that we've talked about, people have a hard time maintaining relationships, jobs, or functioning in society as well. And if you are injecting you get other infections which you weren't looking for. So at its most basic level, harm reduction recognizes that everybody, every human being needs or deserves to be treated with safety and dignity. And also harm reduction recognizes the fact that addiction is not a moral failing. It is a chronic disease. We've talked about what it does to the brain. It is a brain disease, and there is treatment available. So that is the basis of harm reduction. And now also we have medication for opioid use disorder. And using these medications, which is another aspect of harm reduction, it improves treatment outcomes, it saves lives, and it reduces all the other things that we talked about in the previous slide. Now, for those of you who are in healthcare and you've worked in the hospital or in the emergency department, one of the things you see is that people who come to you with substance use disorder related symptoms, they don't wait for long. They usually sign AMA or they just elope. And some of the reasons they do that, I have put here for you. And they also recognize that there is stigma out there. They know that when you are talking to them, you really aren't looking at them as people. You aren't really taking your time to sympathize with them. They can read the body language and they know that you really don't care about them. So one of the harm reduction tools we are trying to have everybody in healthcare be aware of is get rid of that stigma around people who use drugs. So what exactly is harm reduction? So it is basically a number of practical strategies and ideas that are aimed at reducing the negative consequences associated with drug use. And also, it is a movement, a sort of a social justice movement built on the fact that every human being desires or, needs your respect. And we should treat them with respect and as human beings with a chronic disease. And also harm reduction employs a number of strategies that meet the people who use drugs where they are at. No value judgments, please. And we need to bring tools that makes it easier for them to use in a safe environment and also reduce mortality. So for those of you who are physicians, physician assistants, nurses, nurse practitioners, we want you to adopt this culture of radical acceptance. Addiction, substance use disorder is a disease. It's a chronic disease. Like any other chronic disease, treat it as such. The way you treat your patients with hypertension and diabetes is also the way you should treat patients who use drugs. And one of the things that you need to do is get rid of that stigmatizing language. And some of you have used that stigmatizing language before. That's okay. This is 2023, and we are here talking and discussing. We need to improve. Now, I will just concentrate on this, and I know Dr. Shannon and Dr. Hardin have already talked about naloxone. This is very important. It can prevent mortality. It is a very useful drug and tool to the effect that even the state of California has been encouraging to make naloxone as widely distributed as possible. And also at the California Bridge, we have ways of helping you get free naloxone for your patients. Normally, we are mandated by law. Each time you write a prescription for narcotics, you also have to concomitantly write a prescription for naloxone. Unfortunately, the prescription for naloxone, only a very, very small percentage gets tendered in. So if a patient actually lives with a toolkit, or a family member leaves the emergency department or the hospital with a toolkit in hand, that's actually very, very helpful. And please contact us and we can help you get your own stash of naloxone you can give to your patients. And also, one of the things that my good friend, Dr. Roniti, has been advocating is not only a test for fentanyl in all the emergency departments, but also fentanyl test strips for your patients, so that they can know which of the drugs that they are using has been contaminated with or adulterated with fentanyl, as Dr. Hardin has told us from the previous presentation. And some self-injecting practices, if at all possible, don't eject, smoke it, snort it, or ingest it. And like Dr. Hardin said before, again, I repeat, do not use alone. Call your other buddies or your good friends and say, hey, buddy, I am going to shoot here. Can you just make sure that I will be okay? Clean yourself first with alcohol swabs where you're going to inject. Do not share or reuse needles. Use sterile equipment. And also for those of you in healthcare, if you know where they have syringe exchange programs, or if you have a syringe exchange programs, advertise it. Let people know that, hey, they can come in, drop in their used syringes and walk away with new syringes. Screen for HIV and hepatitis C. And these are the other harm reduction tools that are available, and I'm not going to go over each one of them in the interest of time. So thank you very much for your attention.
So I just want to give you all a brief overview on what's going on nationwide with Xylazine. And this is a very general overview. I'll try to keep it short so that we can get on to our panel of experts talking about San Diego, but I did want to give you a perspective on what's going on nationwide to base that on. First of all, I am a drug intelligence officer. That's my title. I work for the Office of National Control Policy under the Office of the President in the HIDTA program, or the High Intensity Drug Trafficking Program, specifically, as you know, the San Diego and Imperial Valley HIDTA. Just a quick history on our HIDTA. Was created in 1988 under the Reagan administration, and is now headed by our current director is Dr. Rahul Gupta, of course, under the Biden administration. There are 33 HIDTAs throughout the U.S., and within those 33 HIDTAs, you'll find an overdose response strategy initiative to cover all of those HIDTAs and all of those areas. That's, again, what I work in is a public safety, public health collaboration, and we do most of our work through SUOPT here in San Diego. So I'm very honored to be here in front of you working with this group. So Xylazine, what's going on nationwide? So in 2022, the CDC's data showed that more than 2/3, 68% of the reported 107,000 plus drug overdoses in the United States involve fentanyl. And Xylazine has been increasingly detected in these fentanyl products across the nation. Just another quick graphic from the CDC to show you the rise. From 2019 to 2022, you'll see quite a rise, a steady rise in Xylazine detected and co-involved in overdose deaths throughout the country. And kind of self-explanatory, but you'll see as they start to get dark, that's where Xylazine has been detected in more and more overdose deaths throughout the country. So xylazine, as you may know, and as I think Dr. Hardin mentioned earlier, is also known as trank dope, also Philly dope, and you'll see why in a second if you don't already know, and the zombie drug, same thing. The Biden-Harris administration during the RX summit in April of 2023 announced that it was going to designate, for the first time, fentanyl combined with xylazine as an emerging threat to the United States. And just last week, Dr. Gupta, our director at ONDCP, unveiled a new plan to address this problem. The one thing, it's a public health and a public safety component in each, but there's also a scheduling component or a hopes for scheduling to regulate it. I just wanted to make a note that New York and Pennsylvania have already, because of their problem in the Northeast, scheduled this, or rather regulated it from a state perspective. National overview and comparison. So let's wanted to get a couple of basics out of the way. There are subcultures of drug use unique to specific regions of the U.S. Historical predominance of the Northeast as an opioid use culture rose many decades ago. And there's a history of IV heroin use in Northeast cities that you don't see here in San Diego. Also, white powder heroin is historically common in Northeast cities. I was a San Diego police officer, detective supervisor, etc., and never saw white heroin ever outside DEA labs and things like that, but not in the street. I'm sorry, I think I may have skipped a slide here. So regional use and cultural differences, that's the main reason that I'm giving you this overview, because we're going to talk about San Diego. And we need to know that San Diego does not have an established IV opioid use culture like Northeast cities do. The role of stigma in San Diego, needles and heroin use is huge in forming the way that people who use drugs here in San Diego. And there is also the consideration of recreational, or the perception of recreational use versus the hardcore drug use that was seen in the Northeast. I'm sorry. Pills are more palatable under that cultural difference that exists here in San Diego. And that's why here in San Diego, you saw the prevalence of fentanyl in the form of pills. As my colleague, Special Agent Garcia, is probably going to talk about later on. This whole thing started with pills, with counterfeit M30 pills in San Diego, whereas in the Northeast, it infiltrated their heroin supply that was already out in the streets. So that was a big difference. So you're going to see more smoking of powder. San Diego is drug use culture is based on methamphetamine culture, which is entrenched here for many, many decades. And we basically, the users here base their use styles and modes and methods on the original methamphetamine culture, and not as we see in the Northeast on a needle culture. So let's fast forward to Philadelphia, which has been called the epicenter of this epidemic, especially as it relates to xylazine. Just a few photos of what's going on in the Kensington Avenue area. They actually have an area there called Needle Park, where you see a lot of this. And you're going to see some of these folks, I wouldn't use this term, but on YouTube and Reddit forums, you see them referred to as xylazine zombies, and this is why, because this is how they end up looking after they're under the influence. In 2021, of note, 90% of the dope tested in Philly, 90% of fentanyl and other drugs contained xylazine. So the Northeast, let's focus on that for a second. Reporting from DEA's 23 field divisions show that the Northeast is basically king when it comes to xylazine in the dope supply. General trends across the Northeast, you're going to see that packaging is different than in San Diego. They use glassine or wax folds, stamped for branding. more than they do plastic baggies, which are still common, torn plastic baggies, or they put it in the end of a Ziploc baggie and tear off the Ziploc part. Intravenous use again predominates. Heroin contains very little heroin. It's mostly fentanyl, and more, especially in Pennsylvania and surrounding areas, it is being adulterated with xylazine. New York, New Jersey, Massachusetts, and much of the Northeast, same thing. It's very common. You're going to see that Maine is a little bit different as we go on, but also xylazine is more and more prevalent. One thing to note, xylazine is getting mixed in at the mid-distribution level and street level, not coming across from Mexico as far as we know, and from the intelligence I'm getting in the Northeast, they're seeing it being mixed at the street level and mid-level. So in case you guys didn't know what a xylazine, what the glassine bag, I didn't. It's these things that they put your bakeries in, and sometimes they use wax paper instead. This is what they look like when they're out in the field or in the street, and people are using them to package xylazine adulterated fentanyl or just fentanyl. These started with heroin back in the day and have continued. The trend hasn't changed. General trends across the Northeast, xylazine is domestically purchased or tends to be. Parcel delivery is huge. People order up from Chinese websites, especially in the Pennsylvania area, I'm sorry. And parcels have been tracked to Puerto Rico, which I think also Dr. Hardin mentioned. Puerto Rico was originally, there's a big Puerto Rico to New York City connection, and Puerto Rico in the early 2000s developed a xylazine problem. They were seeing xylazine mixed into their heroin, used alone, and now in their fentanyl. New York area enforcement operations, according to my counterparts out there, have seen evidence of xylazine being converted to powder form from the liquid form and stored alongside fentanyl, where as it's being cut into the fentanyl supply. So they've done search warrants, and there's Tupperware with dried up xylazine right next to the powder fentanyl, getting ready to be mixed in. General trends across the Northeast to continue. Colored fentanyl, you're going to see rainbow fentanyl, especially violets, light pinks, light greens, light blues, pastel colors. There's generally no nexus between the color of the fentanyl that we're seeing in the street in the Northeast or across the country for that matter, and the potency of it. The colors are just basically a marketing ploy or a marketing scheme. Xylazine has already been mixed into the powdered opioid before the user usually acquires it, and that was part of the problem that led to its rise in the Northeast. The drug dealers were mixing it in for various reasons, predominantly because it makes it cheaper for them. It gives them added value, and by the time it was acquired, when they thought they were buying heroin or fentanyl or whatever it was, they were actually buying a mix that they didn't know of. And then there's really no way to know outside of testing. Now, I just wanted to comment real quick, especially of interest maybe to some of our harm reduction folks, that some areas, Vermont in particular, is offering FTIR or spectroscopy testing at user sites, whether they be needle exchange or whatever sites they have out there. They're offering that testing beforehand for users to have at their disposal. Here's just some photos of what it looks like when it's packaged. There's the light pink, the light blues. Also, you're going to see it not just in that waxine or glassine and wax mode, but also you're going to see it in the plastic baggie still, like you see in San Diego and other parts of the country. General use trends: the Northeast tends to be an intravenous use culture, although there is smoking. I put this picture in here because you see a lot of the smoking in other areas: Chicago, the Southwest, San Diego, of course, and wanted you to see what it looks like when it's actually being practiced. Pills are still ubiquitous throughout the country. You see a lot of these rainbow fentanyl pills. Let me go back. The blue M30s are still all over the place, including here in San Diego. General trends of use across the U.S. and packaging. Xylazine is, of course, on the rise nationwide as an emerging threat, and it's seen in overdose deaths and law enforcement seizures across the country. Xylazine is almost always seen in every state, every ORS team that I talk to, and every expert that I talk to, almost always seen in combination, almost never used by itself. Of course, we do see it mixed in with some cocaine, some fentanyl, some methamphetamine, but predominantly fentanyl and other opioids. This is true in both fatalities and drug seizure evidence. And xylazine mixed into the drug supply is being done domestically, again, mid to street level. No evidence of fentanyl coming across the border that way. However, I'm going to open that up to perhaps some of our experts chiming in on that later. Again, mixed in with fentanyl. I think Dr. Hardin, I think it was, or maybe Dr. Robinson as well. Dr. Robinson did mention Philadelphia has said that xylazine gives fentanyl legs. That's one of the main reasons that users have incorporated. It's the old school heroin feeling. That's why some users actually say they like it that way. Some educated opioid users who have used heroin in the past and have that experience want to recreate it using xylazine. From the drug dealer's perspective, it's cheap and it's a low-cost cut that also enhances the user's experience. So it's a win-win for them. Across the Midwest, fentanyl has become number one king out there, and they have seen xylazine rising, as well as in Chicago. Chicago is a major distribution hub for the U.S., and as it gets distributed, xylazine gets distributed out as well. They are seeing it as their own emerging threat and emerging drug trend in Chicago. Some things to note about Maine. Their packaging is a little different. They have these, if you see these finger pressed kind of things, those get cut in, and they almost never see the glassine bags or the wax foldovers. They see the plastic baggies torn up, the torn plastic baggies or plastic wrap. Drugs for guns is also a major thing in Maine because of the availability of guns there. I'm going to skip over that. Throughout the U.S., Florida, Texas, there's a rise in xylazine, and I'm just going to leave you with this. I showed it before. This is where Pennsylvania is, and this is where we don't want to be. And my good luck to the rest of the country as well. Hopefully, we can stay out of Pennsylvania's predicament and not be there. So just remember, 90% of that fentanyl and other drugs are being adulterated with xylazine in those areas. So just some of my sources, there will be in my PowerPoint, and this is my contact information.
Good afternoon. Thank you, everybody, for participating and giving us the opportunity to be here. For those of you that are not familiar, HSI, Homeland Security Investigations, we are the main investigative arm of the Department of Homeland Security. We're responsible for conducting investigations into transnational criminal organizations that are exploiting our borders. So that ranges from drug investigations to weapons smuggling, essentially any kind of investigation that touches an international border, we have the primary jurisdiction over. In San Diego, one of our biggest focuses and one of our biggest threats, obviously, is the drug threat. With that, we are partnered very strongly with HIDTA, as well as with our partners at DEA and other agencies that have a similar mission as us. In San Diego, to address some of what we're talking about today, some of the things that we have seen specifically as it relates to xylazine and fentanyl is that since 2016, we've had a 2,375% in overdose deaths in San Diego County. We went from 33 in 2016 to upwards of 817 in 2021. As a result of that, we were tasked by the United States Attorney's Office to come up with a strategy to help address the overdose issues here in San Diego. We're doing that through the HIDTA program under what we call Operation Citadel, which is comprised of 3 parts that are focused on the interdiction of drugs as they cross the border, and then focusing on large cargo loads coming across the border. And lastly, the newest part of it is the FAST team, the Fentanyl Abatement and Suppression Team. FAST is a multi-jurisdictional task force that has participation from all of the 3-letter agencies. HSI is the lead, but we have partnership with DEA, FBI, U.S. Border Patrol, Customs and Border Protection, NCIS, state and local participation, to include some of our biggest partners being the San Diego County Sheriff's Office, as well as the Escondido Police Department. This team is comprised of special agents and detectives that focus only on fentanyl as it impacts San Diego County. For instance, today the guys were out and they made a controlled purchase of 1.8 kilograms of fentanyl, and this is almost a daily occurrence for the team. We're seeing fentanyl that's crossing in both powder and pill form now within San Diego. Following up on some of what was just talked about by Alex, we are seeing significant amounts still of the blue M30 pills coming across, but we're also starting to see a lot more of the rainbow colored pills as well. To date, through our agency as well as through CBP, we've seen at least 4 different instances of fentanyl that also has tested positive for xylazine. It does appear consistent with the national trends that this was added after the fact, that it wasn't smuggled into the country in that format. And frankly, I believe that there's probably a lot more of it. I just think that it's a trend that we haven't necessarily been as focused on this coast, and therefore we're probably missing some of the testing to be done to confirm how much more of it is actually here. From the perspective of what we're doing here in San Diego, the FAST team is very focused on how fentanyl is getting into San Diego County. So we have a focus at the border of how they're crossing it. And then most importantly, how we're able to prevent it from getting into the hands of the users, specifically vulnerable populations, to include schools, jails, people with mental health issues. So we've started to aggregate information and intelligence to target very specific dealers and smugglers within the community. With that, we have a partnership with both the U.S. Attorney's Office and the District Attorney's Office, where we're getting very, very strong prosecutions on anybody that is targeted in these cases. So the things that we're looking for and working with in conjunction and in parallel with some of the other teams, such as Team 10, DEA Team 10, who you'll hear from later on today. But we're starting to look for juvenile involvement, fentanyl being introduced into institutions. We are helping when Team 10 doesn't take one of the overdose death cases, or it's outside of the area that they work. We're focusing on the people selling the pills or the fentanyl that is leading to an overdose death. And then lastly, we're targeting subjects with significant criminal history to ensure that they are no longer able to continue to peddle these drugs into our community. We've been very successful since we stood this up a little bit over 8 months ago. We've had over 60 arrests already. During Operation Blue Lotus, which was a DHS-led initiative, we seized over 4,000 pounds of fentanyl during the operation, and we increased our prosecutions by almost 200%. So we're very focused and committed to the enforcement efforts that come with this. But I think just as importantly, we're focused on partnering with Health and Human Services, substance abuse, all the social services and non-governmental organizations to address the addiction that comes from these drugs as well, not just trying to arrest the problem away. The last thing that I'll talk about, and something that was brought up by Alex, and I think is important for people to be aware from the perspective of HSI, we as a agency have some initiatives that are very focused on not just interdicting pills or going after the organizations that are smuggling them, but actually getting into the supply chain and production of these pills. It's been pretty well announced over the media recently that we have an operation called Operation Chainbreaker that is based out of HSI El Paso, and it's focused on the dismantlement of organizations that are responsible for the sell and the manufacturing of the pill presses that build the blue M30 pills in Mexico. So we're targeting the organizations that we know and that we can track back to doing the illicit pill making, and are actually interdicting those machines before they can even get into the hands of the organizations. Additionally, we have some other operations that are very focused on working with our partner agencies from other countries to interdict the precursor chemicals before they are able to be turned into the final product, whether that be fentanyl, or also we focus on any synthetic drug to include methamphetamine. These operations are very successful. I think it's an important aspect that we need to look at in the current fight on synthetic drugs, because we're stopping the ability for these drugs to even be made. So rather than just interdicting them once they come into the US or focusing on trying to catch the people selling them, we're going after the organization and trying to stop their ability to make it so that it can't even be smuggled in the first place. Here locally in San Diego, we have several cases that fall under both of those initiatives that are very focused on specific organizations that are using the precursors to make dope that's being then smuggled into San Diego. Overall, HSI and our partner agencies are very committed to the partnership with HIDTA, as well as the Opioid Taskforce and all of our state and local partners, to really have a significant impact on this drug that is, wreaking havoc within San Diego County and across the United States as a whole.
What my focus is going to be is on what is the current legal landscape, the status of the law as it relates to xylazine itself. And you've heard the background. Dr. Robinson did a great job talking about the history of xylazine. So I can actually just skip this slide. Look at that, one slide already down. And we can talk about horses, cows, dogs, and cats maybe in more detail later. One important thing I did want to say when I got to this slide was that there is a group of veterinarians who they use xylazine on a daily basis, oftentimes multiple times a day. Xylazine currently is not a controlled substance, at least federally, it is not a controlled substance. And the concern that some veterinarian groups have are that when you designate a drug a controlled substance, that brings with it a whole host of regulations, strict requirements, reporting requirements, how it's handled, how it's stored, how it's disposed of. And the concern is that that's going to limit the supply to veterinarians who use it on a daily basis. And it's absolutely critical for what they do to treat our animals. And it'll make the cost go up. Cost for them that they are either going to have to absorb or pass on to you and me. But let's talk about controlled substances. And federally, there's the Controlled Substances Act, and that's a huge body of law, way too much to get into. But what I want to focus on and what's important for at least this discussion that we're having is the scheduling of drugs and how do they fall within these different schedules and what does that mean? And there's a lot of things up here written up on this slide right now. I'm going to try and make that easy for you to understand. When a drug is scheduled, think of it this way. Is there a currently accepted medical use for the drug? If there is not, there's no currently accepted medical use, then that's a Schedule I drug. Everything else has a currently accepted medical use. And that means there's validated medical studies that show, scientific studies that show that it's useful for some sort of medical condition. Okay, now we're talking Schedules 2, 3, 4, and 5. And what distinguishes among those remaining schedules is what is the likelihood of abuse resulting in severity of dependence, whether that's physical dependence or psychological dependence. And the greater that risk of abuse and dependence, then you're talking Schedules 1 and 2. Those are the high risk, high abuse, high dependence. Then 3, 4, and 5, it decreasingly gets less severe. So just thinking broadly about that becomes important because when we look at xylazine in the current state of the law, federally, there has been a bill introduced into Congress called the Combating Illicit Xylazine Act. It's making its way through the legislative process. It is not the law yet. But what that bill, if passed, what it's going to do is it will designate xylazine as a Schedule 3 controlled substance. And so thinking back to that chart that I just blasted through very quickly, what that means is Schedule 3 would be there is an accepted medical use for xylazine. And I assume that thinking is veterinarian use because there's none for humans that I'm aware of. And then the risk of abuse resulting in physical or psychological dependence, that falls in that moderate to high level. So that would be a Schedule 3. There's other things that are going to come with this act if and when it passes, and it looks likely to pass. And that's going to be that the DEA and the FDA are going to have to come together and report back to the U.S. Attorney General a number of things. Those things are going to include what is the prevalence of xylazine use throughout the country. You just heard Mr. Kirby talk about, well, how much of this stuff is being diverted from the legitimate pharmaceutical supply that veterinarians are using. They want to report back to Congress within a year of those findings. How much is being imported from China? Are there analogs of xylazine, much like we see with fentanyl analogs? Are there analogs of xylazine that we need to be aware of and concerned about? And then also, should it stay in Schedule 3? Or should it be moved in either direction among the federal schedules? So we'll see what happens with that law. It was introduced in March of this year, and those bills can take quite some time to get through, but it looks like it's going to pass eventually. You've already seen Dr. Gupta displayed. He was discussed earlier, but back in April, he designated xylazine mixed with fentanyl as an emerging threat in the United States. First time ever that a drug or combination of drugs has been labeled as an emerging threat in the United States. Well, what does that mean? What happens with that? Well, the first thing that happens with the designation of being an emerging threat is that there has to be a national response plan that is drafted. And you heard from Alex de Armas that plan actually has been drafted. In April, there was a deadline given for this national response plan to be written. It was, in fact, drafted and distributed just July 11th. It was posted and it's publicly available. I've read it. There's a lot in that national response plan, but it focuses a lot on these main areas. There's going to be investigations into testing for xylazine, data collection, evidence-based prevention, treatment, and harm reduction strategies, supply reduction, the scheduling that I just talked about. Where does it fall within the Controlled Substances Act? And then just further research as to the xylazine. In those areas of focus within this national response plan, there'll be a number of government agencies that now have 60 days to report back their implementation plan back to Congress. This is what we're going to do to get these answers and to focus on these particular areas. So that's the national response plan in a nutshell. The FDA, as most of you I'm sure know, they're responsible for making sure that all of our food supply, our vaccines and drugs, the medical devices, all those are safe and that they can be distributed throughout and used by people in our country. They have something that they did recently. Back in May, they put in an import alert regarding xylazine. And so all that really does is it stops xylazine products that are coming from abroad into the United States when those products meet certain conditions or they fail to meet certain conditions. And if the products are coming from certain identified firms, pharmaceutical manufacturing firms, or they're specifically identified products that the FDA has determined don't meet our requirements, then they go on what the FDA calls a red list. And what that red list does, it stops the further distribution of those products once they make it into our country. They don't get examined, but it just stops it from making into our flow of commerce and reaching the American public. Now, the firms can get off of a red list by just proving to the FDA that we've taken the steps to correct whatever deficiencies there were. There are other reasons listed here that you can stop these shipments of xylazine and hold them up until they can prove that they are worthy of going on into the stream of commerce, including when they're misbranded, just means lacking in instructions, and or adulterated, which you would think one thing. We've talked about adulteration in the context of the FDA alert. Adulteration really means it hasn't really met it has not met the application process, hasn't been approved through the application process as an approved xylazine product to make it into the country, where it doesn't have a pending application, and therefore we're going to stop the product. It doesn't make it illegal. It doesn't make it a controlled substance, and no one's getting arrested as a result of these import alerts. But it's one step the FDA has already taken to kind of slow down the influx of unauthorized xylazine into the country. Now, when we look at the states, each individual state, of course, we make our own law in California, Florida, Illinois, all across the country that relate to drugs. There's the federal law that will apply to all of us, but then each individual state will have their own controlled substances laws. And as recently as June of this year, so just last month, as far as I could find, there have been 11 states that have designated xylazine a controlled substance. They're not waiting for that federal Combating Illicit Xylazine Act to pass. The states have already acted on their own. So far, 11 of them have either passed legislation designating xylazine a controlled substance, or it's pending, and it looks like they're going to pass. And so what I did is I created this map that you're seeing now. In that map, the highlighted states in red, that's where these states are the states that have the xylazine laws in place or pending. And not surprisingly, as you can see, a lot of it is up in the Northeast. And as you've heard, this flow of xylazine throughout the country, it started, that epicenter, the Northeast of our country, but it is now flowing at a rate tremendously in the South, then followed by the West, then the Midwest, and then the Northeast. And I think the Northeast is last only because it originated there. I'm talking about the growth, the increase in the amount of detection, both in the illicit drug supply and in the number of overdoses where xylazine is being detected. So it's coming our way. I predict that we're going to see a lot more of red, meaning states that have enacted xylazine legislation flowing westward across this map in the near future. So what are we doing in San Diego County? What happens? So here, at least in terms of legally, it's not a controlled substance in California. California does not currently have xylazine, any legislation pending declaring xylazine a controlled substance. But our attorney general, our state attorney general, did join in with a number of other attorney generals from 36 different states. They drafted a letter that they presented to Congress supporting the Combating Illicit Xylazine Act. My prediction, again, bold predictions, but I think the writing is on the wall that this is a bipartisan issue that all the states are looking at very closely, and they are going to pass some form of xylazine legislation. My prediction is California will do the same. When and if the federal statute passes, I predict California will likewise pass it, and I predict that California will designate xylazine a Schedule III drug, just like the federal drug statute is going to do, at least initially. If they do that, and when California does that, then xylazine, I'm predicting, would be classified as a depressant and then fall within the criminal codes that would punish drugs like methamphetamine, ecstasy, and LSD. So I blasted through that. I'd really want to have some time for questions, and there's some great questions. Thank you for your attention and for staying with us.